My name is Samir Mehta. I'm an orthopedic trauma surgeon at the University of Pennsylvania. I'm also chief of the trauma service here at the University of Pennsylvania. I'm very excited to talk about this technology. It is a novel technology, and anytime we talk about new technology, there's always questions about cost and, workflow, and do I really need it? And, we kind of get stuck in our ways. We kind of come up with patterns and formulas and algorithms that seem to work. And so where does it fit into my practice? And then should I be the first to adopt it? We just heard a great talk about early adoption and how it could be utilized, but do I really need it? And let somebody else figure out the nuts and bolts of it, and then hand it off to me. And then the other aspects of any time you talk about novel or new technology, and I would argue this isn't new. It's new to orthopedics. It's new to me, but it's not that new in terms of other subspecialties that have been using it. But where's the value? How do you convince a patient to go get a tomo as opposed to some other imaging modality? And why is it important for you as the practitioner and the patient as a recipient? We saw some great cases already of articular fractures, which on a 2D image, a plain film radiograph, AP and lateral, you can make it out, it's there, but to really understand that fracture in multiple planes, you need to be able to see it in multiple planes, and that's going to dictate potentially whether it needs surgery, the kind of reduction that it needs, and where you're going to place your hardware. And all of that really, there's plenty of data now to show that three-dimensional understanding of fractures really makes a big difference in the way you treat them. I think ultimately what VolumeRAD really does, and digital tomosynthesis does, is it takes an uncertain situation and provides some certainty to it. It provides you additional information that could be utilized in helping make care decisions, and we've seen already some fantastic examples of that, and I hope to show you a few more in a few minutes. In my mind, every time I see an injured patient, the algorithm is very simple. I'm not very smart. It's binary in some ways because it's easy to make binary decisions. Is this an operative injury or is it non-operative? If it's operative, what's my pathway? What am I looking at? What am I trying to do? If it's non-operative, am I sure it's non-operative? And if it is non-operative, how do I assess my progress and assess my potential either maintenance of reduction or loss of reduction, so we're not going back into the operative algorithm? And it's all about decision making, and now in this day and age, shared decision making with your patient. So having these images to show them, I think, is really important. I'd like to highlight VolumeRAD and with a couple of really, I think, unique cases. Unique in the sense that you can see, as we move forward through this presentation, you can see how there's a direct benefit potentially of VolumeRAD. So here's a case that demonstrates the utility of VolumeRAD. So this is a 89-year-old female. She had a previous hip replacement that's old. She had a fall at an outside hospital or outside facility. She's an independent ambulator in the assisted care living facility that she's at, and she broke her pelvis. Interestingly, she had an anterior ring injury that was seen on x-ray, but no CT was obtained. She was followed up in an orthopedic surgeon's office 2 weeks later. They got an x-ray. The anterior ring was starting to displace. They transferred her to us. Because she was an independent ambulator that wasn't able to ambulate and having significant pain, we went ahead and we fixed her pelvis with a screw in the back and a screw in the front. You can see those are the purple objects that are not the hip replacement that are on this post-op CT. The reason we obtain a post-op CT is these screws are placed percutaneously, and we want to make sure that they're safe, that they're not in the joint. In this case, it doesn't matter, but they're not also in the sacral tunnels affecting nerve roots, because everything we do is essentially off fluoro in the operating room, and it's somewhat blind. And it's been our protocol to get post-op CTs. Well, if you look at this rendered image, so we've already gotten the axial, coronal, and sagittal cut, so we've exposed the patient to all this radiation. We get this rendered image to see where our imaging, our implants are at, and you can see in this rendered or ghost image that you can't really tell what's going on with the screws. Are they in the right place? Do they go in, out, in? Are they contained? And it doesn't really help us very much. If we go forward to the VRT image, so this is another rendered image off of the CT that we're going to see very shortly, You can't really see anything in this. The hip arthroplasty hardware takes up there's so much noise around it. I can't even see my screws in the bone, which I guess means they're safe, but I don't really know because I can't really see where they're going inside the bone. I can't see what's going on in the back of the pelvis at all. While this is a great fancy 3D image to look at, it gives me absolutely no information in terms of what I'm looking at. The interesting thing is when you go to the VolumeRAD, which is our next image, and you play the movie, and you'll see this movie as it's playing. As you watch the movie of the pelvis going through on VolumeRAD with the digital tomo, you can now see where the screw is. You can tell that it's in the canal. This is the anterior screw we're looking at. You can do the same thing for the posterior screw. And I can get as much, if not more, information from this VolumeRAD for this case as I could with the CT without obtaining nearly as many images, without the rendering of those ghost images or the VRT images. And this movie really shows that that screw is safe. It's in the tunnel. It's right where we want it to be. And the hardware is essentially appropriate for its location. So a very good example of what we want to do with this series of images. We'll go on to the next presentation, or the next patient, and this is another interesting or unique patient. This is a 58-year-old physician who has had thigh pain, and I'm going to zoom out in a second to kind of give you a bigger perspective of his fracture. But here's his sort of large perspective of his fracture. He had a hip replacement. He then had a femur fracture below his hip replacement. He was then fixed with plates and screws. That didn't work out so well for him. He got then fixed with a rod, and then he was ultimately referred to me with this x-ray, and it looks pretty good. I mean, you can see the tip of his hip replacement. You can see the rod going up his femur, and if you zoom in on the fracture, you can see I think the fracture is healed. I look at this and I'm like, man, that looks pretty good. I don't understand why you're having thigh pain. Maybe it's just that you've had multiple surgeries. This guy is active. Maybe he's just trying to push too hard. I don't really know, but this looks pretty good. It looks healed. I mean, I would look at this APN lateral and without a doubt tell you this fracture is healed, with the exception that his clinical story isn't making sense. And again, when you get that step back perspective a little bit, it really looks like he's healed. Having said that, it's clear that he's not healed when you look at the tomo picture here. The tomo picture will tell you pretty clearly that as we move through this movie, that he's not healing, and he's not healed at all, actually, as you see the fracture line very, very distinctly on the lateral tomo image. And this is where, while you could get a CT scan, and we did, there's a lot of noise from that CT, and it's really hard to tell. But the tomo makes it perfectly clear that this patient needs an additional surgery to get him to union. And so these are just two real sort of interesting, complex sort of case examples of how the technology can really work in your practice.